What time is it? Why don't we go ahead and get started? Thank you everyone for joining us this afternoon. My name is Greg Wu. I'm an emergency physician and medical intensivist, associate professor at Albany Medical Center. And today You've Got This, best practices in the care of the critically ill boarding patient. I have an awesome panel here today. I think we're gonna have a really cool discussion. I'm gonna go ahead and introduce folks. We have Dr. Raghu Seethala, who is right over there. Raghu is an emergency physician and surgical intensivist at Brigham and Women's. He is the chief of Division of Emergency Critical Care and the medical director of the ECMO service, director of Thoracic Surgical Intensive Care Unit, and the co-director of the Cardiac Surgical Intensive Care Unit. That's a lot of titles. We got Dr. Nathan Haas. Nate is an assistant professor of emergency medicine at the University of Michigan, where he serves as the assistant medical director of the ED-ICU, also known as EC3. His scholarly interests include ED-based critical care delivery models, DK, and out-of-hospital cardiac arrest. We have Dr. Michael Sherman was not able to join us, nor Dr. June Gorin. Both of them unfortunately had some health crises, but stepping in is Dr. Ryan Barnacle. Dr. Barnacle is an assistant professor of emergency medicine at Brown University and a specialist in emergency critical care. He's a current director of the emergency critical care and EM resuscitation education. Dr. Namita Jayaprakash is an EM medical intensivist at Henry Ford in Detroit, Michigan. She serves as the associate medical director for quality and patient safety in the Department of Emergency Medicine at the Henry Ford Health System, system-wide physician lead for a sepsis program. Her span of work and focus within EM critical care includes describing models of delivery of critical care in the ED and evaluating ED-based critical care consult models. Dr. Cam Waldman is, there he is, perfect. Dr. Waldman is an assistant professor of emergency medicine at Albany Medical College and a specialist in emergency critical care. He practices in both academic and community emergency critical care in the Albany Med Health System. And then finally, Dr. Luke Duncan. Dr. Duncan is associate professor of emergency medicine and surgery at Albany Medical College, is dual trained in emergency surgical critical care, and currently is the division chief of emergency critical care, director of CVICU and the ECMO program at Albany Medical Center. And I'm realizing we don't have, last but not least, my good friend here, Dr. Alex Bracey, is the associate professor of emergency medicine at Albany Medical College and a specialist in emergency critical care, and the fellowship director of the Resuscitation and Emergency Critical Care Fellowship. Alrighty, without further ado, let's go ahead and talk about a case. I'm going to ask my panel what their opinions are of what we're going to do about this. So I want you to imagine that you are in a busy ED night shift, and just like any other night shift, they bring in a 19-year-old male with EMS who's found unconscious at a rave. EMS intubates him. When he gets here, the nurse gets the vital signs with a temp of 36.5 degrees Celsius, a heart rate of 123, a respiratory rate of 12, a blood pressure of 92/59. You do a good thorough physical exam. You find that he does indeed have an endotracheal tube, and it does appear to be in the right place, so that's good. He is currently being vented with a volume control of 350 by 12 with a PEEP of 5, 100% FiO2, because we put every patient on 100% FiO2. And the patient also has a med alert bracelet saying he has type 1 diabetes. He gets some labs, nothing too exciting. He screens positive for cannabinoids and amphetamines. He's got chemistry, he's got that blood gas. You call up to the ICU saying, hey, I got an intubated patient down here that needs an ICU bed upstairs, and they say, I'm sorry, we don't have any beds tonight, he's gonna have to stay in the emergency department. Who has had this patient before? Who had this patient last week? Right, I think all of us, or most of us. This is a super common situation that's bothering us in every emergency department. But I want to ask, what are some things that we should be doing? What are some things that we want to look at for this patient? So I'm going to ask, we'll start with Dr. Barnacle, because he's actually the furthest on my left. When do you stop resuscitating this patient? How do we resuscitate this patient, and when do we decide that the resuscitation is done for this guy?
When the resuscitation is done?
Yeah.
Okay, so that's fun to talk about and think about, but I think it's difficult to be precise about when that phase ends and the next phase begins. I think in general it's going to vary by case and by disease process, but the resuscitation phase is the most active doing phase of the patient's care, and I think a good your goal is you're just trying to arrest the immediate disease progression and keep the patient alive. I think practically speaking, my sort of benchmark for when resuscitation is over is like when I can leave the bedside. Because during that phase, it's really minute-to-minute reevaluation that requires me to be with the patient. Once I feel like it's safe for me to leave the bedside, we kind of enter the next phase of the patient's care.
Great. No, I think that certainly that's a very fine distinction that we have to do as we think from an emergency physician to now maybe thinking a little bit more like a medical intensivist or a surgical intensivist or just even having to be a resuscitationist. Let me ask the group this: what other workup would people want to see? What are some of the things that you're looking at this patient you might want to think of? I'll turn to my right. I'll ask Dr. Bracey. What do you think?
Yeah, you know me. So I mean, this is a sick person, intubated in the field, type 1 diabetes, and like, look at that gas. I'm all scared of this person. I'm intubated. I'm scared of the intubated, the type 1 patient, type 1 diabetes patient who's maybe in DKA before. So we know that this person's going to be hanging out with for a super long time. So we want to confirm their either presence or absence of ketones. I want to know what this person's mental status was prior to being intubated and the like. And if I get any indication that it's anything beyond just, who knows? Maybe this person was like slammed to the ground or something like that, hit their head, and while dancing aggressively or something like that, and they've got head trauma. Who knows? So I'm like a fairly aggressive pan scanner with the sick patient. This person meets my threshold probably for that, unless there's something in the history that will tell me definitively otherwise. So imaging is something I want on this patient for sure. Additional labs, definitely beta hydroxybutyrate like fluid, DK protocol potentially, and really aggressive and close attention to this person's vent if they're going to be hanging down with us, because they need to ventilate more.
Excellent. So I actually think you bring up an interesting thing, but the pan scan. We throw pan scan around a lot. Who in the audience says they're going to scan this patient from head to thigh with contrast? Pelvis. Okay. I don't know. I feel like my radiologists aren't quite that precise. I always get some thigh, maybe a little bit of knee, some elbow there. Who pan scans this patient? See, maybe some hands. Oh. All right. Okay,
As
good.
my mentor says, scan above, scan below. So.
I maybe sense a little bit of disagreement over here. What are your thoughts? Would you pan scan this patient? Yeah.
I don't know if it's a disagreement necessarily. I think the key here would be, you asked originally, like, what else do you want to know? I'd probably want to know a little bit more about the history. So why did they feel like they intubated? So if EMS is still available, is there anything else we can get in terms of history of what were the circumstances? What did they stumble upon? Is there anything environmentally? I think from an intensivist lens, I am looking at this going, yes, my emergency medicine brain is looking for the immediate what happened and what could be the worst case scenarios. What other injuries am I missing? And some of these getting that data can certainly be influenced by what are you seeing, and if you're not seeing much, but you still have that in the differential, I think the CTs and the imaging are really important. So I guess I lean a little bit more on what do I know about the history, and then what do I see on my examination findings, and where is my differential landing at that point, and then how am I ranking it? So that might influence which imaging modalities, but sometimes, yeah, that includes a full CT.
Fair enough. So certainly, I think everyone would agree a little bit more history would be great. I wish we could always get more history out of our patients. Sometimes this is all I feel like I ever get from EMS was we put the tube in, we found them, we put the tube in, then we walked away. Who is? I'm gonna poll the group. Who is moderately concerned with this medical alert bracelet? Right? We don't always get that, but sometimes we get a little bit. I'm going to ask Dr. Haas, what makes you concerned about this patient, maybe with some of the medical history?
I'm trying to think of what you're getting at here, but I think
I'm leaving it very open-ended. I want to see where you want to go with this.
yeah. I think, like we brought up earlier, is this patient in DKA, yes or no? We probably have enough data points here to say no, unless there's, a concomitant sort of triple acid-base sort of disturbance. But I think, seeing the bicarbonate's normal and seeing that the anion gap, I think, is normal if my mental math is right. So I think, the question, is this person in DKA, yes, no? The serum ketones measurement would be helpful to answer that. But then I think I'd be curious what their home regimen is. Clearly they need insulin, and so how much, how sort of, what's a baseline dose, or, how much does this patient need on a day-to-day basis to help, start to guide how we bring that number back down.
Okay, very good. Poll the group. Who has a beta hydroxybutyrate in their institution, gets on a regular basis? See a bunch of hands. Oh, okay, great. Finally disseminating around the world. Why do you say beta hydroxybutyrate? Like, why is that important here?
You can check urine or serum ketones. I think a lot of EDs getting a urine is an uphill battle at times, to say the least. And so oftentimes I think there's convenience and pace are quicker to get a serum assessment than a urine. This patient would probably get a Foley, and so you'd probably get a urine pretty quickly. But I think, from a matter of convenience and practicality in real sort of day-to-day life. And the disclosure for me, I'm not an intensivist, just emergency medicine. And so, I think I have probably the most EM-centric brain instead of the inpatient side brain too. But I think the ease of access to a serum level is probably going to contribute to it.
Okay, great, excellent. All right. Why don't we change tactics a little bit? So we've talked about a little bit about the workup and maybe what we're going to kind of think about as we try to get this patient to a little bit more of a stable place. Sometimes we talk about being in a maintenance phase, right? Sometimes we talk about what are we going to do for this patient going forward. I'm going to toss this question over to Dr. Waldman. Dr. Waldman, what are some things that you might think about, like, okay, this patient's going to be here with me for probably for the foreseeable next few hours. What are some things that you want to think about?
Yeah. So at the bottom of my little sheet that I use to help the residents and the students that come onto our ED critical care shift, I have at the bottom who's their person. So I just want to put a plug in for that. So talking to whoever it is that's in this person's life to get a little bit more of a history. And so for this, I think it's really important to start reaching out to those people fairly early on, like right after the resuscitation is done, like finding out who's this person connected to, an additional history. If they're not in DKA, then obviously we want to think about on the maintenance phase, start that process of putting on their long-acting insulin, because how many of us in this room have seen somebody in the emergency department who has type 1 diabetes, comes in for some other issue, and then slips back into DKA? Has that happened to anyone? Because it's definitely happened at our institution. Yeah. So that would be a really important thing to do. The other things that are important to do are to think about, if you're an ED intensivist or you're managing a critical care patient, but maybe you're handing off to somebody who's just going to be handling the entire department, so they might not have as much focused resources for that patient. You want to kind of think about setting them up for success. So sometimes for these patients, I'll put in more frequent labs than I might otherwise do in another setting, where maybe you have 2-to-1 nursing ratios. So making sure that maybe for this patient, you would have Q1 hour finger sticks. Maybe you would do Q4 hour lactic acids, and maybe even Q4 hour blood gases. Something that you might not have to do in the ICU, because you can clinically examine the patient more easily with nurses, but just things that, so when you leave, if there's anything that comes up in the blood work that's raises alarm for your ED colleagues, they can just be clued into that right away. And then just another plug I'll put in for kind of a similar thing for boarding ICU patients is, in our emergency department, we tend to be a little bit more aggressive about putting things in A lines, which you might, not even have at some institutions in the emergency department, but we're a little bit more aggressive about it, especially if the patient is showing us he's hypotensive. Again, just because it's something that can alarm you if the patient's decompensating, if you don't necessarily have closer eyes on that patient, if your nurse has 4 to 6 patients at a time or something.
Awesome. No, I think these are all really good kind of system-based thoughts, right? To think about what are the resources around you and what's the resource going to follow you. Why don't we change tacks a little bit? Who is unhappy with that blood gas? Right, a little bit, right? Now, there's a giant squeaky box in the corner that has a really important button on it, and it's the silence the alarm button. And that's what I tell the medical student to go touch that button every 2 minutes, right? Who does that? I've been guilty of that. What do you think? Are we happy with these ventilator settings? Are we happy with this blood gas? What are some things that you may want to start thinking about, or that we should start to think about? Yeah, well, or either.
I was like, are you asking them or me?
Listen, I assume that you're going to be the expert on this, so I'm asking you. But
I mean, there's several things that are a little bit concerning. So we have a PaO2 of 84. Normally that's good, but we're on 100% FiO2, so that's a pretty low PaO2 for being on 100% FiO2. And then there's obviously the pH, which with a PCO2 of 61, so we're underventilating the patient. I don't know what's going on with this patient, but I'd also, want to know their height and just make sure that, we are ventilating them appropriately, based on their ideal body weight. So I think immediately, without imaging or anything, I would probably just crank up the PEEP a little bit more because 5 of PEEP is not a lot, and then that may be that we just have some atelectasis, we have some whatever that's going to respond to opening up a little bit more alveoli. So I think easy things to do. 350 seems not like a lot of tidal volume, so I think I wouldn't even change that. I would increase the rate, increase the PEEP, and see if I can dial down the FiO2, and then get a gas again in 10, 15 minutes after I made my ventilator changes. And I think the key thing here is, when can I walk out of the room? I can walk out of the room and the pH is maybe above 7.2 when the MAP is 65 and the pulse ox is 90% or greater. Thinking about things I need to accomplish before I'm really in that maintenance phase. I wouldn't look at this gas and say I'm in the maintenance phase. I'm still in the acute resuscitative phase.
Okay, all right, no, that's fair. Do you have any sort of methods like how you think about PEEP with this kind of patient, or how you titrate it?
Real easy is just follow the ARDSNet protocol. So in our ED, we have a ventilator protocol that we adopted during COVID. It's just dial in, as if it's not an obstructive airway disease process. If it's not, sorry, I'm looking this way because this light is blinding me.
Oh,
I don't have my Eclipse glasses anymore. But if it's not asthma, COPD, obstructive airway disease process, then almost everybody should just can just be started on standard ARDSNet protocol and PEEP titration based on that. And then if things are going or awry, then we can start doing bedside PEEP optimization based on the patient.
okay, good. Does no? I think that's a good usable answer. So using PEEP FiO2 titration tables. Do you like the high? Do you like the low? Do you use some blend?
I mean, just the standard low one. If they fall off the wagon, then we have to come back and think about doing other things.
Okay, yeah, fair enough.
But nothing about this patient, screams out that there should be in Florida ARDS based on they were at a rave, they were normal at that time, unless they had a massive aspiration event that we don't know about. We'll find out on our X-ray or imaging.
Okay.
Or is it right main stem?
Yeah. Yes. Yeah, and that's the other thing.
Yeah.
Is the ventilator alarming? Is there other things going on?
Okay, good. So we got to pay attention to the squeaky box. Start junkie. Okay.
What I was gonna say is, I think a practical thing from all of us, everything that's been said, is like, look how easy it is to be, where we're saying this piece, this element, each that, look at the vent, look at the person's, their A-line, their social factors. I think like a very practical element that everyone in this room will probably, if they're not already doing, take away and go back to your next shift is the next time you have a critical care boarder, prepare with some kind of structure to round on your patient by systems. I can't tell you how often at sign out, when I'm signing out, or receiving sign out, or whatever, my colleagues are, and often myself, the residents are, say, oh, this person's boarding for MICU, and they're going to get a bed eventually, follow up a gas or something like that. But there's this whole set of organ systems that goes unaccounted for. And it's very, very, very easy to lose track of all the small elements, the minutia of PEEP and vent titration, ideal body weights, and the like. So having a system, a rubric, a template for you to round your critically ill patients by system at the time of sign out and demand the same when you are receiving sign out, I think is essential to the excellent care of these patients boarding in the emergency department setting.
Well stated. I like it. So let's say the patient's been here for now a few more hours and we still have no bed in sight. Like every night shift, it means that we are just becoming a little bit more full with every patient. Dr. Junket, what are some meds that you want to think about? We talked about like starting insulin on this patient, maybe if they were in DKA, starting a DKA protocol. Are there any other meds that we should be thinking about?
Definitely long-acting insulin. I mean, like I said, everybody has walked into a situation where that's gotten missed. I'll ask the most hated question in all this. Have you considered sepsis? Because that's a real thing. This patient has abnormal vital signs. They are intubated. Their blood pressure's a little low. They've got an altered mental status. So do you need to cover them with antibiotics? Do you need to culture them up? Do you need to start thinking about instituting ICU prophylaxis? Do you need to think about your kind of standard VAP bundle? Have you ever had a nurse in the ED successfully administer chlorhexidine mouthwash to your patients?
I don't know if we even have chlorhexidine mouthwash.
Yeah. So things like that, stupid things that I would do even beyond just ordering medications. How many patients have you received like this that are completely flat? Every single one of them. So sit that head up. That'll help. Does he have enteral access to decompress his stomach? So we can see that stress ulcer when it shows up. Should we start him on stress ulcer prophylaxis? Do you have a protocol for that? Should we use Pepcid or Protonix? DVT prophylaxis for this guy that's laying still? Probably. So those are kind of the big things. And then, the MedRec is really the least glorious thing that we do as part of our, critical care shifts. So trying to figure out who this person is, where they get their meds, are they in some sort of state database? Are they going to withdraw from something that they're on regularly? Are we forgetting his seizure medications that he just didn't get updated on his med bracelet? So those are the big things that I want to miss. Is he an asthmatic? Is he getting appropriate puffers and whatnot?
Perfect. No, I think those are all very valid points. Do you have a protocol or a system that you use personally to try to remember all this? Because that's a lot.
No. Actually, I do. So at the bottom of my critical care note, I've got a little prophylaxis. On our template, we actually have DVT prophylaxis, GI prophylaxis. Am I feeding this patient? That's one of the most commonly things that never gets started. Probably won't get started in the emergency department, but you can have patients boarding, essentially starving for 3 days. This guy, we're not super worried about it, but then we put him on a long-acting insulin on a dose that maybe we're guessing. So then when you end up chasing your glucose. So.
Can I just add something to that? So when we think a lot about critical care, long-term care in the emergency department, a lot of it is structures you implement just to kind of create a culture of how to take care of these patients who really ideally shouldn't be taken care of in the emergency department, right? But so Greg and some of the other colleagues got together and created, an epic note that you can just put into the computer, and it has a drop down of sort of everything you might want to think about, sort of like a checklist that's pre-programmed into your note with things like prophylaxis, organ systems based, and it's something that really anybody in our emergency department, any of the attendings or residents can implement as an example of a type of tool to help create a culture or structures to help you take care of these patients.
Yeah, and just to add to that, because I think if you're out in the audience, this sounds like a lot. You have a ton of other patients to deal with. How am I going to deal with this level of minutia on one patient?
along with rounding checklists, along with note templates, I think you need to go back to your institution and advocate for an order set. So it can be a little bit pared down from, say, the ICU inpatient admission order set, but it should be kind of system-based. It should be checklist kind of formatted so that we're not neglecting the things that may not be a problem right now, but could turn into a problem 18 hours later. And sort of along with that, one thing that we're trying to do at Brown is, establish a culture of checking in with the ICU every 12 hours. So 8 a.m. and 8 p.m., we kind of have a phone call with MICU triage, and we just kind of telephone round on all the patients that are pending transfer to the ICU. And, the reality is someone sicker might come in and might bump the patient you think is going up next. And so you're like, wow, this guy I kind of had written off as going upstairs in the next 15 minutes is actually going to be with me for the next 4 hours. And so I think being in constant, regular contact with your colleagues upstairs is definitely helpful. And that way you have you're talking through it, and there's another kind of set of eyes on the bigger picture of the whole flow of the department.
And then I think, just to add to that, I think you have to make it specific to your institution because the problems are different at each institution. And, if your average boarding time is 3 hours, then it probably doesn't make sense to do all of this, right? And you probably need to focus on things that are more important within 3 to 6 hours of the patient. But if you have issues where it's 12 hours, you're doing 12-hour check-ins and you're waiting that long, then probably the order set should be right off the bat. You have an ICU patient, that they're going to not be in the ICU for greater than 6 hours, and it makes sense to institute all these things because we have to balance, with the ED nurses that are taking care of all these other patients, do they really have to go in there at, in 2 hours after their stay and put this patient on protonics that doesn't have, a GI bleed? No, it's probably not that important at that moment. But, if we know this patient's going to be there for 10 to 12 hours, yeah, at some point it's important to do that. So I think tailoring these protocols and order sets to your institution. For example, we have, do you guys have psych border problems where they're waiting for inpatient psychiatric bed? We have, a protocol. If they've been here more than X hours, then we actually go and do DVT prophylaxis and do all normal inpatient things. You could have something similar to that. If your patient's in the resus bay or waiting for an ICU bed for more than 3 hours or 4 hours, then it's important to hit that order set and have all of these things in there.
Okay, great. So it sounds like what we need is some sort of protocol or some way of keeping this all organized, whether it's a checklist, an order set, maybe a little bit of both. We're gonna advance the case just a little bit further, just to change discussion up a little bit. So, of course, it's 5:30, and you got 90 minutes to sign out. There's still no ICU bed available. The patient has now received some insulin, some IV fluids, and you get some repeat labs. Things are looking markedly better. We instituted some nice changes with the ventilator, and we got a much better blood gas. And the nurse comes and talks to you, said, hey, the patient's now starting to wake up. They're starting to move their arms. They're following commands. You go see them. They're pointing at the tube. Who's had that scenario, right? Exactly. It's always 90 minutes before sign out, right? If it was like 15 minutes, it'd be like, great, I can do something. It'd sign them out. But no, we got to do something at this point. What was that? Yeah, rock your own? Yeah, there we go. That always makes event compliance so much better. Why don't we talk about this? So this patient has no disposition in sight, but is really still on a ventilator. What are some things that we may want to start thinking about? I'm going to turn to Dr. Haas. What do you think? What are some things that we should think about with a ventilator on this patient at this point?
Yeah, and so I think sounds like it's getting close or ready to liberate from the ventilator and potentially extubate. And,
wait, could you say that one more time? Liberate from the ventilator in the ED?
Yeah.
Are you crazy?
Yeah, so ED extubation is not on the forefront of a lot of our minds, but I think that it's been really powerful and striking to me. The more intensivists I've talked to, they'll often quote that extubation is like their most gratifying procedure, or it's, not procedure per se, but something that they get a lot of satisfaction from. You sort of see someone that came in really bad and you see them on the right trajectory, heading the right direction. So I think trying to shift my mental framework to that this is like a positive procedure, which we pretty rarely have the opportunity to do in the ED. But so we've looked at ED extubation data, and there's really not much to guide it. And so in 2020, as COVID was just kind of ramping up, we at Michigan sort of started thinking about, are we going to be extubating more patients in the ED? What data is there to guide this? Do we need to anticipate, prolonged, 48-hour stays in the ED, and do we need to sort of prep the ED for extubating patients? What do we need to be ready for that? So there's two good published kind of cookbooks or how-to guidelines, sort of position papers that are published saying extubation in the ED should be safe. One from 2013 by a Dr. Gray from Toronto, and one from 2019 out of Penn, I'm going to mispronounce it, Nwakma. And so both of those were sort of like cookbooks for, this should be within our scope of practice. But then as far as outcome data, there's really not a whole lot. And so the first was from 2011. Weingart et al. At Stony Brook had 50 patients that were extubated in the ED. And so all 50 of those were for trauma. And so if you think about, combative or agitated, intoxicated patient that needs intubated to facilitate the workup, they sort of published on the safety of extubating 50 of those patients in the ED. And then we looked at Michigan data retrospectively in our ED ICU, which is not exactly, apples to apples, but in the ED ICU we've found 202 patients that we extubated in a 4-year period. And something I thought was interesting from that data was that 55% of those were by non-intensivists, or emergency physicians like me, and so less than half were done by someone with subspecialty critical care fellowship training. So I think sort of supports the concept of ED extubation. But I think the cookbooks and sort of good rules of thought are thinking about the types of patients that might be ready to extubate. And so one is intoxication, the patient that we're presuming was intoxication for this patient. But then of our bigger cohort, the ones that sort of shine through trauma, seizure, end of life or compassionate or palliative extubation, and then being intubated for procedure, which for us is normally EGD for something like a food bolus or upper GI bleed. And sort of, it's important for us to assess the extubation readiness and think about, what check boxes does a patient need to hit before they're ready to extubate or to think about extubating. And number one, sort of, obvious type moment, but is the reason why they were intubated reversed? Has the intoxication cleared? Has the, depressed mental status normalized? What was the indication for it, and has that reversed itself? Are they able to oxygenate and ventilate on relatively minimal settings? And so probably something like 40% and 5 of PEEP or some sort of reasonable low ventilator settings. Are they maintaining oxygenation and ventilation on something like that? Might consider a spontaneous awakening trial and or spontaneous breathing trial, and put the patient on 5 of pressure support for 20 or 30 minutes and sort of make sure that they can fly on that. And do you expect the patient will be able to maintain their airway once the tube is out? Is their secretion burden minimal enough? Has their mental status cleared enough to where they're following commands, and sort of things of that sort? But then I think importantly would be, was the intubation itself easy enough? Was this a angioedema that was fiber optic intubation and a 10 out of 10 difficulty? That's probably not somebody to jump to extubate quickly. And what's the patient's anticipated clinical course? Are they going to be going back to the OR for surgery or something else where it just sort of doesn't make sense to remove the breathing tube just yet? And so I think a lot of that comes from ICU literature, but there's sort of 2 ED extubation position paper type publications to pull from, and I think we can sort of draw from that.
Great, that's awesome. I love it. So it sounds like there are some published methods about how to do this. I'm going to ask the rest of the whole panel, does anyone have any other tools that they like to try to extubate or try to assess is this patient ready? Like any other things that you try to keep in mind as you think about, can you take this tube out?
Yeah, there are a couple like nitty gritty things. I personally don't like to extubate patients that don't have like a size 10 tube that, barring someone who has a size 10 tube that doesn't have a cuff leak, that makes me apprehensive. In other words, said better, I like somebody to have a cuff leak and, be able to lift head off of bed, obviously follow commands like deliberate, give me a thumbs up with your left hand, blink twice, etc. Those are things that make me feel much more confident about extubating. But I think that especially, in general, I totally echo what you're saying, and I patient selection is key. Depending upon your boarding situation, this may or may not be as necessary. But where you can, learning how to, I think that this should be a skill set that's taught as emergency medicine. I do. I think that this, in particular, those who have no injury in trauma or intoxicated, intubated for anticipated course in terms of like airway protection, quote unquote, whatever the hell that means. When they start to wake up, sparing an ICU bed that may or may not exist, not delaying somebody's course from being extubated. I mean, if you've intubated and then extubated anybody, even in a short time frame, you hear them coughing out garbage from their lungs for like the next 5 minutes. I mean, it's not a benign procedure. And so as soon as you're able to safely extubate patients, I think this is one of the, I'll as a non-intensivist but resuscitationist, I will definitely echo that is like one of the most satisfying things that you can do. You feel genuinely, not necessarily like a mechanic, but like a doctor when you're doing it. And you're hastening this person's ED course, you're hastening this person's ICU course, or totally removing it in some cases. I mean, it's meaningful. So you should all, if this is something I would immediately go develop a protocol for, and look for patients where you can do this, because it's really wonderful.
Greg, could I just add something?
Yeah.
I would echo.
I'm sorry. I think Dr. Jayaprakash had the microphone first, but we will come back to you.
Sorry. I'll be quick. I'm going to echo a lot of these points that were made, and I think what Dr. Haas walked you through is no different than my daily role in the ICU. When I'm doing my rounds and trying to evaluate who needs to be extubated, those are the steps. I think the challenge in the emergency department is more from a systems-based approach. Just like how there's an apprehension as an emergency physician, your nurses, respiratory therapists, pharmacists, everyone around you is probably going to have that same level of apprehension. And so a lot of it is getting the team on the same page and doing a lot of the whys and investing in that time of really walking through and saying, this is the criteria that has gotten me to that decision point, so that everybody in the room understands it and really sees this as, okay, this is different, this is not what we usually do, but it's okay because the patient is at that point in their course. That can take you a long way in introducing any kind of out of the ordinary type of approach, I think, in the ED. So especially when it comes to a lot of these longitudinal critical care things, our nurses in particular, ED nursing is very different from ICU nursing. So it's one factor not to forget that nurses and pharmacists and respiratory therapists may feel also a little bit outside of their zone.
Fantastic point. I love it. Dr. Barnacle, I'm sorry, I have not forgotten about you.
Yeah, so I think just to add on to that, a potential solution until it becomes culturally acceptable at your institution on a case-by-case basis, reach out to your intensivist with the specific consultation question. Hey, I think this patient that is destined for the ICU because they're intubated is ready to be extubated. Would you mind coming down and lending your expertise? And I find that in reality, that's something that will get help to the bedside to facilitate that if they can avoid, filling another ICU bed. So feel free to reach out for help when you don't really have the experience.
Awesome. No.
Before we move on, super fast plug. Tomorrow, Friday, we're studying this prospectively, and Dr. Waldman's going to be presenting this at a small 6-minute session, so look for that on Friday, please. ED extubation.
Follow that guy. All right. Tell you what. Last thing before we advance this case, I'll just ask. It's 5:30. It's 90 minutes to sign out. we are probably not going to get this patient discharged or disposed before the change of shift. Are there any things that we may want to think about telling our colleague at 7 a.m. things that we need to watch out for? Let's say that we are going to extubate the patient. I'll ask Dr. Waldman, what do you think?
So I think one of the most important things for these boarding ICU patients in the emergency department is, your kind of standard systems-based sign out. But then also just anticipated clinical course is so big. So again, I'm trying to set up my colleagues who are coming on, who might just be managing the general department. They might not be able to focus on the ICU patients. Trying to set them up for success. So do I think this patient is going to get better and better and better? And if so, what might I give to my colleague to help guide them to so they can have confidence that's true? Hey, their gas is improving. They're still following command. We're having a spontaneous breathing trial that the respiratory therapist is going to come doing downstairs and do in the next 30 minutes. Follow up on that, make sure that's going okay. So if you think that the anticipated clinical course is going to get better and better and better, just try to give the roadmap of how to follow that course for your colleagues. And if you think it's going to get worse, similarly, try to give the roadmap of how they can pay attention to the evidence that the patient's getting worse. Like, hey, over the last 2 hours, they've actually gone up a little bit on their Levofed. If they continue to go up, this is what we're going to do. And the other thing, just to echo the point that we just made, is it might change based on your awareness of who your team's going to be that inherits the patient. So maybe the team that comes on is really uncomfortable with managing extubations. So it might not be the case for this patient that would be an appropriate thing to do if the next team coming on is not going to be comfortable managing the post-extubation exams. So I've definitely changed plans depending on who I'm signing out to.
Excellent. I think an argument to say conscious of your resources around you. So fortunately, we do decide to extubate this patient because we have a good protocol in place at this institution. They pass a spontaneous breathing trial and a spontaneous awakening trial. The patient extubates. You assign the patient out to your colleague in the morning, telling them if the patient remains stable through the morning, could probably be downgraded from the ICU to a general floor bed after 6 hours. All right, so we talked about a case of what may commonly happen in a critically ill boarding patient in the emergency department. Let's talk about some general solutions. Let's talk about some things that hopefully the audience can take home and maybe have something to reference in the future. I'm gonna toss one to Dr. Jayaprakash. Are there any resources that you would recommend to our audience?
Yeah, I think to start with, I'm gonna just get a straw poll of who is primarily managing their boarding ICU patient. Okay, and who has a boarding patient is taken over by an ICU team or another care team, okay? And who here has a ED ICU or sort of an adjacent physical? Okay, so it's an interesting mix of people. And the reason I ask that is because I think the first thing, if you're going back to your institution and trying to figure out what are some solutions, is to get a sense of, one, what's the need that was mentioned before, what's the problem you're trying to address, and what's the need? And then what are your resources? Can you build an adjacent physical ED ICU? Not always so easy, a lot of upfront costs. Do you have resources like EM intensivists who might fill in for like an ED-based critical care consult model? That's a model that we have at Henry Ford in Detroit. Do you have ICU capacity? So I'm not talking about physical capacity, but your ICU teams, are they able to come down and manage these patients? And so there's a lot of things to think about as to what are the resources in your institution to best develop some of these solutions. But once you get that assessment, some of the key things are really the longitudinal care needs. Take a lot of systematic approaches. You've heard that theme over and over again. It takes taking stock of what can be delivered in the emergency department setting versus what cannot. And I will give you the example of things like some prophylaxis, vent bundles, GI prophylaxis, DVT prophylaxis. Those may be things that you can institute, but enteral feeding may not be something that is feasible because that's a little bit of a heavier lift. What kind of pharmacy resources do you have? Do you have the ability to schedule medications versus you need to do one-time orders, which becomes a little bit more challenging. So now you got to make sure you remember when the next dosing is. Can you collaborate with your pharmacists and figure out ways to prioritize certain things. So as an example, at our institution, our pharmacists are really taking on antimicrobial timing. That's a priority for them. So I have confidence that for my longitudinal care needs for my boarders, at least the antimicrobials, which are a key intervention, they are going to offload me cognitively and ensure that that's being delivered. So really working with taking stock of what resources you have, what is feasible to implement, and then sort of like knocking them off one at a time and trying to pick out what are the solutions. Is it order sets? Is it Epic tools? Is it system-based approaches? Is it team-based collaboration? So I don't think there's one thing that's going to fit every emergency department across the nation, but it's really taking an approach of what is the need and what can be done.
I love it. That's excellent. I think that's a really good, that's a really great answer. I'm gonna ask the rest of the group. Just are there any other solutions that you've tried implementing, or things that you have found that have worked?
So the boarding problem's not going away, right? And we're going to be asked to do more and more as emergency physicians. And I think a nice conclusion to have is that really the ED needs every ED needs a dedicated champion to this problem. And so for the trainees out there who are kind of looking or trying to figure out what the trajectory of their career is, if this is an important problem to you, I would kind of advocate, go out, get the expertise, and propose to your local leadership that this needs its own dedicated position from an operations standpoint, quality standpoint, and liaison with all the interprofessional kind of people that are going to be involved. But you could definitely be the change that happens for the whole kind of group. And I think that's probably key for every individual emergency department.
Awesome. I love it.
I might also be maybe a bit soapboxy and whatever, but I think that some of the boarding, I think that traditionally emergency medicine has allowed itself to be the first hour of care. I think that is no longer a viable plan, and this might be controversial, and I'm not apologizing, but I am at least acknowledging it. And so I think a sense of ownership of our sick patients might be something that would help. Certainly not solve, but help. And I think where we can pick off critical illness, because like one of the talents of emergency medicine is getting stuff done maybe faster, maybe with lesser resources, or in unusual circumstances. So I think picking off low-hanging fruit where we can in terms of critically ill patients and not assigning them to the ICU, or not at least allowing them to linger and languish prior to going upstairs if by the protocols that are established, or your interventions actively that they're improving. I think taking a sense of ownership in that, I think, is enormous. Might be more on an individual basis than on a systemic basis, but it all starts from somewhere. And then to piggyback along that and to reiterate, I think just starting to think all the way through your patients and not just see them for, this is an intubated person. Why are they intubated? Altered mental status. So why is this person unwell? And then what other systems are affected and what other systems need active intervention or passive intervention. I think just thinking about those things and having a checklist really, or a systems-based approach to your critically ill patients is essential to my first point and to this.
Yeah, and this is actually also very fertile ground for collaboration within your institution. So looking at what those patients are that are boarding in your emergency department. Is it your intubated GI bleed? Can you smooth something out with GI where they scope the patient first thing in the morning, and then you extubate the patient and let them go home? Michigan has done that very well. Is there certain points where that ICU-bound stroke patient can just automatically be downgraded if everything looks like it's fine? So just kind of reaching out to the major stakeholders in your institution and really pushing them to make things better.
Just really fast. So we started a fellowship within the last couple of years, and
That's also a solution.
Yeah, but just kind of what Dr. Duncan was saying, I felt like the fellowship was part diplomacy, and that was like one of the best parts of it, because we had these fellows going out into the different ICUs and the hot emergency fellows going out to the ICUs and developing these relationships and connections. And one of my first pediatric attending shifts, it was like very, very heavy PICU boarding night. And I just called up the PICU doctors, and one of our, one of them came in and helped me out. And that was only really possible because I understood their world a little bit, their language, and I understand how to tell them about the acuity in terms of how they understood it. So I think that's important.
I just wanted to add one thing is when these patients are boarding, waiting for their ICU, we should really, their care should not be halted. If there are major things that need to happen, I think it's incumbent on whatever service that's taking care of them, if it's the ICU upstairs, taking care of them downstairs, or if they're under the ED. But I think I'm going to put a plug in here for palliative care. So there are a number of patients that probably have moribund, disease processes that are intubated and waiting for ICU bed. And there's not really a lot of critical care going on. You're not titrating pressors or vent settings. They're just tubed and waiting for a bed. Now, if I work in a cancer hospital essentially as well.
Yeah, a little like cancer.
It is. But there are, services that you could align with, and palliative care being the big one. We have hospice come see our patients, or ICU patients as well in the ED. But just putting a plug in there for these really devastating processes. Palliative care, they are some of the most kindest physicians, and they'll come to the ED, if it's not 2 a.m.
Awesome. Well, I think those are great answers. I know we're a little bit over time. One more. All right. Excellent.
10 seconds.
One last one. Yeah, go for it.
I think we think a lot about boarded, intubated, obviously ICU-bound patients, but we've also had a big problem with boarded general care patients who decompensate and become ICU patients. And I think a framework or operational approach or some sort of safety plan for the best way to manage that problem, because ED boarding of general care becomes ICU boarding. And that was oftentimes a no man's land for us, or how do you coordinate the efforts to that? So, plug to think about that.
I love it. Excellent. More collaboration and more collaborative efforts. I know we're a little bit over time. I know the panel would. I know we got to clear this table, but if the panel will be willing to stick around just for a couple minutes and answer the audience questions, I think that'd be great. Thank everyone for your attention, and have a great rest of your day. Oh, thanks.